Nwama, I think we should start.
Okay. Okay, thank you, Dr. Juma. So, welcome everybody. Today's session will be cardiovascular risk assessment, which is a very important topic again in our practice, and also in when it interacts with medical legal, particularly in aviation industry, both the military and the commercial area. So, where maybe the recruitment and assignment of personnel will be very dependent on cardiovascular status. So this is a very broad and really challenging area. So it's really very good for us to have this discussion in front of seniors and have a framework for our institutions. Still, this topic is entirely depend on epidemiological evidence, the court studies, and there is no blinded RCT. Because of this, you can imagine a bulk of evidence. So what I did is I followed the major societies framework to present, and also according to my moderator, Dr. Juma's recommendations. So with this outline, I will present the introduction, just briefly the history of cardiovascular assessments and Framingham's study. And then with the cardiovascular risk assessment models or tools we do have, together with this strengths and limitations, and then separately the WHO heart chart or risk assessment model, and the stepwise approach cardiovascular risk assessment or pooled court equation model, and finally I will discuss the risk management after we identified the cardiovascular risk, and then we have to manage it, and I'll summarize. So this will be our outline. So I will have a case scenario just to stimulate. Hello, everybody, I'm audible? Hello? Hello?
Yeah, we can hear you. Proceed, please.
Okay. So with this case scenario, I will read it out loud for you, maybe to stimulate the presentation. So a 45-year-old man, apparently healthy businessman, come to you to have test for diabetes as per his friend advice, and upon thorough evaluation, he has never smoked. BMI is 27. Blood pressure is 140 by 45 by 70, and A1C is 6. Total cholesterol is 200. High density cholesterol is 39, and LDL is 110. And a short-term risk assessed was 5.5 by pooled court equation model. And then what would be your next appropriate measures? This man, the A, counsel on the benefit of appropriate body weights and lifestyle modification, and appoint for 3 months with repeat A1C. Do high sensitivity C-reactive protein, ApoB, and triglyceride as available, any of these. C, start anti-hypertension, counsel on benefit of weights, appropriate weight and lifestyle modification, and appoint after 3 months with repeats A1C. And D, this is a low risk, so is short-term cardiovascular risk is low, and the long term is unknown, so we can counsel in that way and we can send him on. The second case scenario is, how do you approach patient, 20-year-old young man who come to you to know his cardiovascular status? So this is a stimulating, and at the end, throughout this presentation, the main objective of this presentation is how to approach patient cardiovascular assessment. And so at the end, we all have this answer, I hope. Introduction. So our current cardiovascular practice is really so fascinating, and we may think it is a state of the art, and maybe we will be excited, but the sad part is still there is no curable, there is no cure for any form of cardiovascular disease, and that is still we are not achieved. And since this is science, we have to still hammer on that. Century long, we've been tied really to very static, for centuries static position, very inertia on the scientific cardiovascular science and practice. Like the hypertension used to be believed as benign and as a part of normal elements of aging, and it used to be thought as benign, and which is necessary to force blood through a stiffened artery in old age. Particularly the systolic one, they used to be believed systolic plus age is normal, which is the maximum limit, until the maximum limit goes to 210 by diastolic of 120. And the diastolic, for some other reason, considered to be as a chief determinant of cardiovascular risk. And this was the belief really very, for a long time, and this was a dogma we used to station on. With this, we paid really a big price, and President of America, Roosevelt, died suddenly in office and from stroke and heart failure in 1945. That was really the igniting point. That was where we believed we have to shift from that position. And it's a surprising one is he was in heart failure, so that even the public was aware of that he is sick. But the president denied, and the physician of the president was saying he is okay, despite his BP is 300 by 130. He was just only on digoxin, and nothing was there to do for him. So this was an igniting, and the successor President Truman, ordered to establish the National Heart Institutes just in 1948. And which became now National Heart, Lung, and Blood Institutes, and it became a big institution still. And that institute initiated the Framingham Court study to determine the cardiovascular risk in the public. So the Framingham is a pioneer, really is a rewarding one. A big legacy in cardiovascular, everything, even I can say every aspect of the cardiovascular care is emanated from this, the modern one is emanated from this Framingham study. And the original Framingham started from 1948 up to 1991 with the objective to determine the cardiovascular determinants or risk factors. And the second generation is, or we can call it, Framingham offspring, which is the children of the original study participants and with their spouse. And the objective was to identify the familial risk status of the cardiovascular. And third generation currently, or we are already on third generation, and since 2000, it is the grandchildren of the original participants. And the objective is to identify the genetic relationship of cardiovascular risk. So the Framingham is really the landmark epidemiological studies that really shifted the practice and dissipated almost these myths or dogmatic belief, which was almost philosophical rather than science. So determinant of cardiovascular when it interacts, that just to stimulate again how we go about it, why we have to combine and consider in terms of total risk or multivariate approach. If you take blood pressure constant systolic like 110, 130, 150, this blue is 130, 150, and the taller one is 170 systolic. As you can see, the 5-year risk of cardiovascular per 100 people is really very low, less than 5 if it is only hypertension. If total cholesterol is 270, or meaning second additional risk factor combined is raised about to 8. If it's smoking added, it's all above 10 per 100 population. If LDL, high density lipid, again reduced, the third risk factor combined on top of hypertension, it increases. And likewise, it increases in the age 60 with all these 4 risk factors. You can imagine it's the risk per 100 is almost more than 45. It's a 46. So this tells us, this study published in Lancet 2005, again contributed a big in our practice, a total risk approach or multivariate approach. Cardiovascular risk management is really yielding very rather than the single risk approach. So this is why we have to combine all of the risk factor the patient has got and calculate and objectively approach our patients. So what risk estimators do we have worldwide? Is there are a lot of number of risk calculator. Out of these, I just have to mention the Europeans, Americans and the Europeans and the WHO. These are the major one, and finally we have to resort to the Americans one, because even though we are not sharing the same environment, the blacks are almost 40% involved in this court, and so finally I will resort to that. But these are the tools we have at the end of the day. So the first one and the pioneer is the Framingham risk score in 1998. The second one is ATP3. Third score for Europeans, as you know, in 2003 and now revised in 2016. Q risk is for United Kingdom. Reynolds is again Americans, both for male and female, that has a risk scoring method. Again, there's Framingham Beta generation came in 2008. In 2013 and 2018 revised now is the SEC AHA pulled the court equation came into picture, and that found to be strong predictor, and now this is the one which is in practice. And the other one in British is the Joint British Society in 2014. MESA, again, is in America. This included the calcium score, coronary calcium score, and again, it's valuable but not universally practicing. And the other one is the WHO, initially developed in 2007, now revised in 2019. And this is with the focus to the socioeconomic status to cover that area, and the WHO developed, and also I will discuss it, please. So the strengths and limitations of these risk estimators entirely depend many factors, but 2 big factors are very important: the broad base and a clear objective, clear outcome. So the broad base is total risk. We have to include all total risk, and the other one is the socioeconomic background, representativeness of the data is very important, and also it has to be latest and represent the current contemporary society. So the broad base and the outcome is clear outcome. So we have to focus not only on the coronary, we have to also focus on cardiovascular disease, including the stroke. If we focus on that, the sensitivity and the yield of this estimator is reliable, or at least very predictable. And so these are the two very important points we measure the strengths and limitations of each of the score. So epidemiological, statistically, these two things are measured by calibration and discrimination. Calibration meaning the agreement of the observed and expected between the
Dr. Nwama, we are having poor sound, so I think can you be closer to the mic?
Okay, I'm sorry. Okay. Hello?
Yeah, it's better now.
Okay, thank you. So the calibration and the discrimination, the calibration is the agreement between the observed and the expected one statistically, and the discrimination is the ability to identify the patients who benefit from statins and from a harmed one, patients who are harmed, differentiating from benefited from harmed. So this is starting from this, depending on this, every of these scoring models has its limitation and strengths. And the very important one is none of these can represent all populations worldwide. And almost all of these risk models overestimates the risk. And because of this, the recommended choice is locally endorsed and validated one is recommended. So briefly to look into the variables on each score model, just briefly, the variables it included and the variables it excluded in the outcome, like the Framingham, the first Framingham is included age, gender, total and low density cholesterol, high density cholesterol, systolic blood pressure, diabetes as a yes or no, and the current smoking. And what it included is the treatment of hypertension. It excluded. That was the weakness side, and the outcome was it entirely depend on the cardiovascular. The coronary status. Again, that was the limitation, as I've said. It doesn't include the entire total risk, and the outcome was not again based on coronary and stroke. So these were the limitation. The second one is the ATP3. The ATP3 now included blood pressure treatment of hypertension, but excluded the diabetes. But by that time, in 2002, diabetes used to be considered as a cardiovascular risk equivalent, and that's why they excluded the diabetes from the calculation as a risk factor, meaning it's already somebody who has diabetes, the risk is obviously above 20, which is high risk. That was a consideration, and they excluded. That was the limitation of ATP3. Again, the ATP3 is only considered the coronary status. The score, European one, the variables they included is the same, but specific to the score is European. It is itself, it divided into low risk region and high risk region. So that is the limitation. It is not representative to all populations. And the other one is it excluded treated hypertension and also diabetes. It's still the diabetes thinking of coronary equivalence persistent, so they also excluded. That was again the limitations. And the outcome was they focused on cardiovascular disease days, only the fatal end, but they did not consider the disability as an end. And the key risk for UK, the specific limitation is they consider even United Kingdom into regions of unemployed, overcrowding, car ownership and house ownership, And even within United Kingdom, they stratified their population that way. So that is a limitation. It cannot represent the other population. So, and again, the diabetes was excluded. The second is the updated farming harms in 2008. Again, it focused on only many outcomes. It now included the diabetes is back now, but the outcome was it focuses on coronary insufficiency, angina, claudication, and heart failure. And so this is a broad outcome, and it's not focused because of this. Again, it shows the limitations. And so the 2013 pooled court equation is really found to be a strong predictor, even though still it's over predicts. The very important adjustment it does is it focuses the hard outcome, meaning coronary fatality or disability, and also fatal or non-fatal stroke. That was a very important outcome. It focuses and it tries to include all the total risk it has to include. And the MESA 2015, and again now the important peculiarity is it included the ethnicity, Chinese of American and Spanish, unlike the other tools. And it also included the coronary calcium scoring as other peculiar variables. And so it's not really every societies and as a public level, it's not possible to score a calcium, and that's why still is a limitation. It's not universally recommended. And the pooled equation is universally, at least at American level, is representative, and now revised in 2018, and that is the one we focus on. The WHO, the peculiarity of WHO is it considered the laboratory-based and the non-laboratory-based variables, and laboratory-based in both the initial and the revised one: age, sex, smoking, systolic blood pressure, diabetes, and cholesterol if laboratory is available. If no laboratory is not available, in low socioeconomic status, we can just consider BMI instead of cholesterol and diabetes. We can consider BMI, and it was the agreement between, I will show you next, the agreement between laboratory-based and non-laboratory-based is fair. So they recommend, and in low socioeconomic status, where there is no physician, every clinician, practicing clinician can use this. And it's really very important for low socioeconomic status like ours. And the bad side of this is not that sensitive, because the WHO objective matters. Their objective is just to pick 50% of at least a patient who deserve, at least to pick 50%. So according to their goal, it may be appropriate, but if we have to look with rigorous scientific perspective, it's not that sensitive. Overall, so the limitations of Framingham was, it was entirely derived from Caucasian, meaning the Framingham city was populated by almost the European dissident. And that was all the data. Now we could not use it anymore. It has to be a contemporary recent one. And the end point, as I've said, is it's only considered the cardiovascular coronary heart disease. And then Stringers was a pioneer initiating one. It framed how we have to calculate, and also it introduced a non-laboratory based model, and it was really yielding at that time too. ATP3, the already limitation, as I've already mentioned, it did not include the diabetes, and the age range was very broad, 22 to 79, and the end point was it only consider again coronary heart disease. Reynolds, again, it included family history, C-reactive protein. This was the strongest, but not include the diabetes, and the population was only limited to very few population area. The European score and the Q risk, It's only European data, and even it's stratified within the European, within the United Kingdom itself. This is the limitation, and the age is limited also from 40 to only 65, and that is another limitation in this score. And the key risk is strength is considered CKD, atrial fibrillation, and the rheumatoid arthritis inflammation, and this is as strength. So overall, the quality of these risk models depend on two things. As I've already said, the broad base and the focused outcome. And this is measured by discrimination and calibration. And so far, the best risk scoring method can only predict about 80%, as NASA reported in publications. And so this requires really regular revision, even in a most reliable estimator. So coming to the WHO risk chart, revised one. So the revised one more broader than the previous one, into 21 low and middle income region, and the laboratory and non-laboratory more consolidated, and age also a fair range of age. It was derived from large prospective cohorts, 86, and also externally validated by 19 separated prospective cohorts. Internal validation means within that population, and external validation means generalizability of in the other data from the other society. So 19 data from the other society used, and the external validation was strong, they said. And this data, almost 66% of the data came from Europe, 23% from North America, and the rest from Japan and Australia, only 1% from North Africa, the Egypt and Tunisia. So the Africa is still not well represented, but they waited for the low socioeconomic status, and so it's acceptable, I hope. So, so the result based on this, after they analyzed the result is 5-year predicted and observed risk were well agreed, meaning the calibration, and the estimated absolute risk difference substantially across region, like 11% in Latin America to 30% in Central Asia, and both in male and female. Really is a discrepant, so they adopted that for each region, and so the result is representative. The agreement between laboratory-based and non-laboratory-based among individuals at high risk, with laboratory-based more than 20% risk, laboratory-based, and more than 97% of men and women were found to be at least more than 10% risk by non-laboratory-based model. So they said the agreement is fair and it's good, but diabetic, 20% risk by laboratory-based, only 45% of men and 25% of women identified as more than 20% risk by non-laboratory model, whereas non-diabetic is higher. So meaning the detection of non-laboratory detection of diabetic patient is really poor, it means. So non-laboratory model is really perform poor, but still useful for resource limited. So that is the conclusion and the drive and the decision, and so it's recommended for poor resource. Finally, the risk category by WHO is color flagged one. The initial one is green, used to be less than 10%, yellow 10 to 20, orange 20 to 30, red 30 to 40, and deep red more than 40. Now the revised one is the revised green is less than 5%, has to be green, yellow 5 to 10, orange 10 to 20, red 20 to 30, and deep red is above 30 or above. So with that risk category, the WHO recommendation for this risk management is the yellow one, or less than 10% risk, is lifestyle modification and every 12 months follow-up, or if it is 10 to 5, every 3 months follow-up. They recommend this is a management approach for a WHO recommendation. The orange one, if the patient lies in the orange range risk category, lifestyle modification, treat hypertension if it is 140/90 or above, and then follow 3 to 6 months. If it is red, meaning above 20, lifestyle modification, treat hypertension to the level of 130/80, start on statins, follow every 3 months, and then refer if necessary. So this is a risk, cardiovascular risk management category and management according to WHO recommendation. So this is fair, at least if not in our setting, in the rural area, really, maybe this is feasible to practice. And so, because the statistically showed the agreement is better. The pooled equation, the pooled equation, court equation is the Americans 2013 ACC, AHA, and also National Heart, Lung, Blood Institutes. These are the 3 major organizations developed this pooled equation. This developed is from several courts studies, and it included both Caucasian and African Americans for the first time, in fact, pooling together, and different from Framingham studies by including total heart outcome, as I've said, the fatal and non-fatal coronary and fatal and non-fatal stroke. And long term, now the other value it's added is we can calculate now from this long term estimation. We can do it for the people up to 59 age. And the other very important value it's added is it included the option of beyond traditional risk assessment, meaning a stepwise approach, including the risk enhancers and the coronary calcium score, coronary calcium score method. So these are the 2 values added, and both internally and externally it is validated. And still the limitation, it has a limitation. The limitation was overestimation of the modern society and underestimation of the Asian ancestry and patient with chronic inflammatory conditions, HIV, C-reactive proteins, CKD, and so I will touch it later. So this limitation is revised 2018. In fact, the 2013 representativeness was really fair. The National Heart, Lung, Blood Institute sponsored courses like ARIC, atherosclerosis risk communities study, cardiovascular heart study, the cardiac coronary artery risk development in young adults, and the original and the offspring of the Framingham study. These are the 4 major studies included in the 2030 pooled equation. And its overestimation is proved by MESA prospective courts involving more than 6,000 white, black, Chinese, and Spanish Americans with a similar baseline. And it found to be, it overestimates almost all races, and the highest is in Chinese. The highest is in Chinese, as Andrew Poole reported in his publications. This is data. Oh, sorry. So this is the data, like this is a predicted one. This is a risk category: women, white women, black, women of white, black, Chinese, Spanish, men, white, black, Chinese, Spanish. So if we see the predicted versus observed, like if we see Chinese women, the predicted was 8%, and only the observed is 2%. So the discordance is 252%. So it's really overestimates the Chinese at highest, but almost every race, but it overestimates the Chinese and both men and women and significantly. So because of this, its overestimation is proved, and the revision came now in 2018. It's revised. Further contemporary data is included in from 2000 to 2012. These are the ERIC, Cardia, MESA, cardiovascular heart studies, Framingham studies, and the Jackson heart studies. These are the 6 United States broad. Now the base is broad, and the data is contemporary, recent one, and revised one is found to improve the accuracy of the cardiovascular assessment estimation in all race and sex subgroups. And by doing so, approximately 12 million of United States adults previously labeled as high risk by 2013, the publication, court occasion was would be labeled as low risk by this revised tool. This is to show the diabetes and non-diabetes one. This is the blue one is as you see it down at the bottom is the footage is observed one. The red is the expected. So in each risk category, less than 2%, 2 to 5, and above 5, the observed is very high, and so that's why it is revised and it's proved and revised in both diabetic and non-diabetic. And so now the overestimation is somehow improved, and patients are necessarily prescribed for statins to be now avoided. Unnecessary prescription is avoided by revising to 2018. So the revised tool, this revised tool is called atherosclerotic cardiovascular disease risk estimator plus. So this is a tool. They already, this equation is already include the risk estimation, the therapy. It guides you how to go with therapy. It guides you how to go with advice, as I put it. This red ink at the top column. So it includes the age, sex, and race. These are the stars are mandatory to include. The systolic blood pressure, diastolic we can include to get the advice. Total cholesterol, high density cholesterol, these are mandatory. LDL is we can include to get a target and advice. And the diabetes, smoking, treated hypertension, these are mandatory. So these are really convenient tool. This has an app, so we can download and we can utilize this, because this is almost 39 million of the weighted pooled population is Black, so it's somehow representative. So I found this is convenient for our setting. Finally, this 2018, what it does is it refined the calibration of the 2013 publication approach, and it preserved the stepwise approach. Rather, it consolidated the stepwise approach. So what is this stepwise approach to risk categorize the patient is, step 1 is traditional risk-based estimation according to publication by atherosclerotic cardiovascular risk estimator plus. And then we categorize into low risk, high risk, and then borderline and intermediate. So high risk and low risk, we can immediately decide. The other next step is now personalizing. We have to personalize, particularly the borderlines and patient who lies in the intermediate. We have to personalize and scrutinize for risk enhancers and reclassify these patients. So because many patients will be missed from this, and so the second step is to recruit and to work out for risk enhancers, or find out for risk enhancers and to reclassify the patient risk. Third step is, if it still remain uncertain, the decision is remain uncertain, like I've said earlier, like in aviation industry, this is where the risk status determination is mandatory. You have to go for CAC score, coronary calcium score, and reclassify, and we have to set it. So these are the 3 fundamental approach in risk, coronary risk, the cardiovascular risk assessment, and this is really developed by the Americans, SEC and AHA, and this is preserved, and the Europeans do not directly copy it, but they use it again, this stepwise approach, and particularly in aviation industry, and also in clinical practice. So what are the risk enhancers? The second step we mean. So the risk enhancers, these are not included in the major quantification in the app or in the application or the calculator. So what we have to do is we have to scrutinize this, and if we get one or more, we discuss with the patient and we reclassify the risk and discuss accordingly. So the family history of premature cardiovascular death. Second is primary hypercholesterolemia, metabolic syndrome, chronic CKD, chronic inflammatory conditions like psoriasis, rheumatoid arthritis, HIV, reproductive health like premature menopause, preeclampsia, eclampsia. These are evidence-based and proven. I'm not going to present each evidence for each, but I will touch some of this. A high-risk race, again, this high-risk race is estimated by pooled occasion, underestimated by pooled occasion. So we have to consider as a risk reclassifying tool, particularly South Asian history. This is because of unprecedentedly low high-density cholesterol and also coronary dimensions. So these populations are quite at high risk. But by pooled occasion, it is underestimated. The other one is hypertriglyceridemia, persistent if it is above 175, elevated C-reactive protein, high sensitivity C-reactive protein above 2 or above, as already demonstrated by Jupiter is a beneficiary, and lipoprotein A, the lipoprotein B, and ankle bronchial index are these are the 12 risk factors we consider as risk enhancers. Any one of these or one or more we can use as a reclassifying and to discuss with patients the risk. Among these risk enhancers, maybe this is the calcium scoring and ankle bronchial index, C-reactive protein, and the family history were tested, and all of them independently predict the cardiovascular event as a univariate and also as a multivariate. If combined, all of these are combined, also it's risk classify, risk predict, and independently also it's risk predict. And so these are the evidence. These are the evidence we do have on this. The calcium score hazard ratio as a univariate is 2.06, as you see. C-reactive protein 1.23 as a univariate. Family history 1.57. Ankle bronchial index 0.6, but it's still significant as a multivariate also. So each one independently predicts the risk factor, and the coronary calcium is as shown in this area under the curve on this graph is zero. P-value is 0.04. It predicts it's add the value on if we had on a risk calculator, it really modestly improve the discrimination ability of the risk calculator. So these are very important values, and after them, these risk factors are really strong to consider. The other one is a preeclampsia. Preeclampsia also would have evidences patients with preeclampsia, both cardiovascular mortality, morbidity with both with non-invasive and invasive one is significantly higher in patient with preeclampsia on evidence, as we can see on this table. Cardiovascular non-invasive in these preeclampsia, non-preeclamptic patients, non-invasive diagnostic procedure, invasive, simple cardiovascular events, complex cardiovascular event, total hospitalization and renal impairment, significant, almost in all significant patient with preeclamptic compared to non-preeclamptic patient. Calcium score. Calcium scoring is really decision aiding. Otherwise, it's not rather than a general screening tool, and it's not helpful in certain very high risk patient again, like in ongoing smoker, strong family history of premature death, and diabetics. These are again even with calcium scoring, again these are very high risk that we have to consider differently. So again, this MESA. In MESA court, by the way, these more than hundreds of publications are there. This is why I say MESA, and the other when I mention the different evidence. These are different, but from the same court. So they identified that the calcium scoring compared patients who were already evaluated by 2013 pooled equation and stratified for statins. Of those recommended statins, 41% were found to have a calcium score of 0, and that was a necessary prescription. And among 589 considered for moderate intensity statins, almost 57% had a calcium score of 0 again, and still a necessary prescription of there. So calcium sensitivity prediction is very strong. That's why used as a decision aid in when there is a patient lies in borderline and intense intermediate category. So this is just to show that what I've said on the chart. This is already depicted on the chart. Patient statin recommended, considered for statins, and not statin recommended. So there are calcium identified even patients who were not recommended for statins. Some of them found to have benefited from statins by calcium score. So the calcium scoring is very sensitive compared to the risk estimators. That's why we use it. So finally, whom do we screen? According to this estimator, is about 40 to 79 without cardiovascular disease or asymptomatic. When do we do that? Every 5 years until 70 reach 79 or until develop cardiovascular disease. A patient less than 40, there is no data, but still we can calculate lifetime risk or 30 years risk. We can estimate. But in patient with a very high risk, we better use it risk enhancer like family history, familial hypercholesterolemia, juvenile type 1 diabetes, or early onset type 2 diabetes, multiple risk factors at early age, and a positive calcium score. These are a very high risk, and rather than estimating the lifetime risk, it's better to consider the risk enhancer and the patient reclassify and approach. The other one is above 79. What do we do? There is no data still. Diabetic patients, the American says if you get proteinuria or retinopathy, you can use it as a risk enhancer for diabetic patients specifically. And the Europeans also, they included a very important tool they included is they graded the age of the diabetes into 10 years, 20 years, and up to 36 years. And if that value added advanced score is utilized in Europe, recommended, and in America, the complication markers like proteinuria and retinopathy also used as a risk enhancer. The other one is if patient already had a vascular disease, what do we do? Still, we don't have a tool, but the European, particularly the Utrecht University of Netherlands, which is well known for its public studies, court studies, they suggest to calculate by, they developed the model and we can use that. So this is the situation, a suitable decision aid algorithm developed by Utrecht University. If we are to calculate the short-term cardiovascular risk, history of diabetes is not there. So if the cardiovascular risk disease is there, we use a SMART on the left side, as you see, SMART risk score. If patient is diabetic, advanced risk score we can use. And if patient age is above 70, we can use elderly risk score. And if it is European score, and if it is American, the pooled equation is the recommended one. And even patient on treatment, lifetime treatment, they patient on lifetime treatment, they score by DAL model, and if patient is on cardiovascular disease therapy, they use smart reach. And so these are the approach for Utrecht University, almost approved by European Society of Cardiology, European Society of Preventive Cardiology, and European Society of Acute Heart Society, Acute Heart Care Society. So this is almost endorsed in Europe, and the Americans also use it, but not universally validated. So we can approach this for a special population. If we fail to use risk enhancer, we can use also this. So finally, managing the risk management is, as I've said, first we have to do the traditional risk based. We have to categorize risk category by traditional risk-based calculator or risk estimator plus. In our cases, maybe the senior will suggest later. And then if it is high risk, we have to go with high intensity statins. Low risk, either we have to counsel, low risk means less than 5, and manage patients and recalculate after 5 years. Or we can calculate longer term, 30 years or lifetime estimate, and for 20 to 59 years of age, we can use long-term risk estimation. If patient lies in borderline and intermediates, now we have to use a risk estimator. Still, if patient remain uncertain, decision remain uncertain, we have to go for CAC and reclassify patients. So this is a final table maybe. So low risk, emphasize on lifestyle modifications, borderlines and intermediates. Now risk enhancer and statins therapy. For more borderline, 5 to 7% is class 2B, and intermediate is strong class A. Class 1 recommendation statin is if risk enhancer is favor for statin, it's a class A. Class 1. I'm sorry, recommendation. And still, if you remain uncertain, we have to go for CAC. And CAC 0 is we can differ statin 1 to 99. We favor for statins at least moderate level, and above 100, statin is mandatory. We have to go with that way. And the high risk, already I've said, is high intensity statin is class 1 recommendation. For diabetes, less than 7.5 is a moderate intensity, and above 7.5 is high intensity statins. And as I've said, we can use the risk enhancer specific to this patient is albuminuria, retinopathy, and in case of Europe, we can use advanced score, which include also the age of the diabetes, the duration of the diabetes rather, up to 10 years, 20 years, and 30 years. So that way it stratifies and it add value. So we can approach this way for these specific populations. And if individual is already, the LDL is more than 190, 900 or 190 or more, there is no need to calculate. We have to go for with high intensity statins. So answer to the earlier question, the question is the young man is found to have a 5.5 risk score, short-term risk score, meaning borderline. So immediately we have to go for the risk enhancers according to the patient's scenario. We have to work up or scrutinize the history and further the history, and we have to decide together with patients. And even at times that patient has got central obesity, maybe he even requires maybe calcium scoring. So this is a stepwise approach. We don't stop and send the patient home. We have to at least go for risk enhancers. That's why what I want to communicate. The second question is a young one, 20 year, maybe university student, maybe because of conscious reading, they may come and ask. So in that case, we can calculate long-term lifetime risk score and accordingly advise. Otherwise, we don't reject them because they are included in somehow in. In summary, the approach, the step approach, already as I've said, and maybe universally more toward universal markers of heterogenesis, and maybe genetic markers will be really the universal and maybe tiebreaker, which we will expect in the future. And the other lesson we've learned, maybe I've learned, is the decision to make institutionalize the epidemiologic status determination of cardiovascular by institutions, national institutions of heart, and later which became a national institutes, national heart, lung, blood institutes, established by President Trutman, was really the shifting, the breaker, broke, has broken the inertia and shifted really toward the excellence. So what we learn from this is institutionalizing is really fundamental to change rather than philosophy-based or maybe fixed myth-based approach, which we really lack institutional-based approach in our setting. Maybe in the future we have to think that way because knowledge is a fluid and it has to be organized. There is distributed and it's a fluid. So we do have huge individuals around, but we do not institutionalize and we don't have our own data still. And we don't know what our future care, cardiovascular or in any other medical care should look like in the future. So this is merely because of lack of institutionalizing the service, I hope. And this is maybe what we've have done. And thank you so much.
Okay, thank you, Dr. Nwama, really for the excellent overview of the important cardiovascular risk models and also the historical background. I think they are all addressed well. I don't want to go to the details of his presentation. I just want to raise few points which we would be using as in the context of our practice. As you know, cardiovascular risk scoring is very important from management of asymptomatic patients with or without risk factors to advanced cardiovascular illnesses. The rationale of this cardiovascular risk scoring is to know which patient benefits from any kind of intervention, be it lifestyle or coronary intervention or any device management. You know, the different interventions are based on the cost benefit. When we say cost, it's both financial and also patient's life, and adverse effect of those interventions are analyzed against the benefits. So though the emphasis is on primary prevention, where it is very important because patients are asymptomatic and the decision to start treatment for asymptomatic patient, as you know, is a very tough issue, and we need to explain in numbers, in quantitative way, to start any kind of intervention. So it will be more applicable as a primary cardiovascular disease. This risk scoring is scoring is very important. Like in acute MI, we do some risk scoring like TIMI or GRACE risk scoring to know which patient will benefit from immediate or delayed intervention or just medical treatment. So this is rather very important as a primary prevention. There are a lot of risk models as he discussed, but the most important thing is we need to identify which risk model applies to a given community, whether that has included adequate population of our practice or not. So we, unfortunately, we don't have much of the models involving African patients, but extrapolation from other studies with similar socioeconomic status would be useful for our country. So, with that regard, as he discussed, WHO, especially for lower healthcare levels, it is more useful in identifying high-risk patients, encouraging patients to further studies. So we can use at lower healthcare levels the WHO risk models, which has got both laboratory and non-laboratory risk models. And the non-laboratory, as he stated, it works well for non-diabetic patients. So for diabetic, it's actually underestimates, if especially if you use a high risk cut point of 20%. So in such situation, using a lower cut point like 10%, and currently in most lower level centers, we do have glucometers, so they can diagnose diabetes. The difficulty is getting cholesterol. So if they identify diabetes, they can refer for further studies, or they can consider diabetic patients as high risk, given all with its limitation of considering diabetes as a high risk in such situations. For tertiary care level in our country, where total cholesterol or LHDL cholesterol can be determined, like in referral centers, we can use pooled course equation, or which has fair representations of African Americans. So we can use that ones as probability for decision making. Okay, of doing the risk models, he has touched on this issue, and every five years for low risk or low intermediate risk is appropriate, but for high risk, it's important we do it more frequently to know whether our intervention has resulted in reduced future events. So the rationale of doing a risk score in primary prevention is to identify those who require statins. That's the most important rationale. And with that regard, with pooled cohort study, 10% is used as a cut point to give moderate intensity, 20% for as cut point for starting high intensity statins. Okay. And with WHO, we have the same recommendations. Aspirin, we do have limited indications based on the risk scoring, unless the patient had a previous cardiovascular event. Okay. And the other rationale of doing risks model is we need to intensify our treatment based on their risk. Okay, like we can wait for with lifestyle modification is in a patient who has got grade 1 hypertension. If the risk is low, like less than 5%, but in those with higher risk, we can immediately start with treatment, even if the patient has grade 1 hypertension. So these are the important topics I would like to touch. And finally, about the CAC score is rather more useful in negative predictive value, as he finally pointed out, than as a positive predictive value, meaning absence of calcium score, meaning or zero or very low score indicates that the patient has low likelihood of coronary artery disease. Okay, and all these models have been tested in India, and uh, it has shown that uh, the WHO risk model and the American College of Cardiology, or AHA pooled score, did poor compared to the Framingham risk score. They did actually in those patients who presented with MI, considering that they just had the evaluation 1 day prior to the MI, and based on that, the Framingham CVD risk score has identified 56% of those patients who developed MI, compared to 13 and 18 and 26 with ACC and WHO risk scoring. And with regard to identifying patients who require statin treatment, NICE guideline has identified better. So this could be a difference due to the difference in hard endpoint of Framingham and others. and it also depends on the community that used. So it may not be applicable to other sites, but anyhow, it's good to know that the risk scores differ based on the community that we are using. So with this, I invite any questions, comments before we end the presentation. So anybody who has got comments, questions? So I think you don't have questions. So thank you all for the presentation, and Dr. Nwama, thank you for the presentation, and congratulations for your first baby. I think that's was the
Okay.
reason we made the presentation today. Okay, and some of the seniors might have not aware that we are going to have the presentation today. So thank you all.
Thank you so much. Thank you.